Good afternoon, everyone. Welcome to our webinar series, Reducing Non-Emergent ED Utilization Best Practices for Primary Care. This is the third webinar of a series of 4. And today we'll be talking about geriatric issues. On January 7th, we will be looking at office strategies and nurse triage. We hope you will join us with that series. And then we have Dr. Michael LaMantia, who is a geriatric medicine specialist and an associate professor from UVM School of Medicine. Co-chairs of the ED Utilization Work Group of the Regional Clinical Performance Committee is Rick Dooley and Tanya Howard. And that's myself. I'm from the Community Health Centers of Burlington. Rick Dooley is from Thomas Chittenden Health Center and is the Health First CO. Our listed series of our webinars, and the first 2 are soon to be available on a recording, and we'll be sending that information out as soon as those recordings are available. The next 2 webinars will also be available as recordings with CME available. To keep your phones on mute during the presentations to keep the background noise down. During Q&A session, I will unmute those that I can mute from here, and we'll open the patient for questions and answers. Yes. Request CME credit. The registration, evaluation, and post-test will be emailed to you within 24 hours along with the slides. And when you get those forms, if you can complete those forms electronically, and then you can save them and send them to Laura Remick at Northeastern Vermont AHEC. So really, are you on the line?
I just got on the line. I apologize. I'm trying desperately to get to the webinar, but I can't. I can get to it, but I can talk at least.
Okay.
Give me a second here. If you give me a line, but I can get to the slide at least. So if I can hold on.
So it is going to give just a little bit of background on the Chittenden County Regional Clinical Performance Committee and the purpose of the webinars. We're having that implemented through the ED Utilization Subcommittee of the RCPC.
All right, so just briefly, while my computer seems to, I'm going to start talking here. So the RCPC, if you wonder what that is, the Regional Clinical Performance Committee is a group of folks who work across, different organizations across the county who are getting together. I'm sorry. Trying to do things at once here. We get together once a month and we work on whatever we think the community needs to work on. So I don't know if you tell me which one up, because mine is building here. Computers, when they work great, they work great. When they don't at all. Yeah, 10%. All right, anyway, so it's a group of organizations. There are the independent practices, which I represent, is Health First, is working at the table. One care there to represent the hospital employed practices, Community Health Center of Burlington. And you see there's a number of other groups that are there, including the Nurses Association, Home Health Agencies, the Skilled Nursing Facilities, Howard Mental Health is there. There's a list. I'm not going to read through the entire list on this. There's a number of folks who are all present. So we get together once a month and talk about which areas we think we need to focus on. We chose to look at emergency utilization specifically to, after looking at some data that showed that ER rates were increasing significantly, despite all efforts to bring them down. So as a subgroup, we got together and discussed different ways to bring the rates down. One thing we talked about was ways to reach out to the practices and to the practitioners and strategies for reducing that rate of ER utilization. As part of the group, we decided to come up with this addressing geriatric issues to send folks to the ER, and that's what today. And I apologize, I can't write the slides, so I'm going completely off the line. Anya, did I miss anything in there?
No, you're good, Rick. Thank you.
All right.
So we'll now have Dr. Michael LaMantia speak to us about avoiding the ER geriatric issues.
Well, so much, guys, for having me speak with this group today. I really appreciate it. I can see some names of the people who have called in for today's webinar, and there are some familiar faces there, or names there. But there are some folks who I haven't had a chance to meet here in our local community. I thought I might introduce myself. I'm relatively new to Vermont. I came here from Indiana about 6 months ago. I'm a geriatrician, and I was recruited to UVM to help increase our capacity within UVM, not particularly of older adults. Over the last several years, focused on vulnerable older adults, trying to understand how those particularly with cognitive impairment interface with healthcare systems, aim towards interventions that improve the continuity of care for those adults. This is a very big topic, obviously, as we know nationally we're facing what's colloquially called the silver tsunami, with the older adults set to increase from 37 million to about 82 million in about a 20-year period of time. This, of course, stress our healthcare system, but there are rational approaches that we can look to apply to help take better care of older adults. What I thought I'd talk with you today about is some big conditions that influence adults and that can affect to a large degree how they interact with the healthcare system and how they access emergency care. Today I'm going to speak with you about dementia, delirium, and mild cognitive impairment. I have no relevant financial disclosures or conflicts of interest to make. I am the recipient of a Career Development Award from the National Institute on Aging. My research is focused around cognitively impaired older adults and more specifically around how older adults with delirium interact with emergency department providers. So, talk are going to be fourfold. I first hope to take you through how we go about identifying the key diagnoses for MCI or mild cognitive impairment. Key diagnostic differences between MCI and dementia. Then move on to differentiating delirium from other forms of cognitive impairment. Sort of sprinkled throughout, we're going to be talking about the influence that cognitive impairment has upon emergency department use. So our overview for this talk is as follows. We're going to review several cases that come from geriatric consult clinics and inpatient services, and these will focus on these three key clinical conditions: dementia, mild cognitive impairment, and delirium. Key diagnostic criteria, useful screening tests, practical management tips, and at the end, I'm going to leave time for you all to ask any questions. I would like to give these types of slides at the beginning of a talk so that if you were to, I guess, get hit by a meteor and pass out for the next 45 minutes, you were able to walk away from the talk understanding what, like, the key takeaway points are supposed to be. Dementia, delirium, and MCI, these are three entities which are very easily confused by practitioners of all stripes. All three of these conditions are marked by cognitive impairment. All three may be revealed when patients present for care in the emergency department or in the hospital environment. All three conditions affect older adults. However, are each different, though sometimes overlapping management strategies. So that's a key takeaway point is that when you take a look at older adults who are cognitively impaired, it's worthwhile to differentiate between the three because there are different strategies that you can apply. Sometimes they overlap, and the key or basic geriatric principles are going to apply to older adults of all types. But when you dive down into each of the three different conditions, specific management strategies that differentiate how we approach care of those older adults suffering from them. I thought I might start off with a case. This is a case of Mrs. Smith. Mrs. Smith is an 87-year-old woman who presents to your clinic for complaints of memory problems. And at this visit, luckily, she's accompanied by her daughter. Unfortunately, as many of you know, that and that's not the case when an older adult comes by themselves. I try to encourage all of my patients, particularly as they get up in years or develop any type of cognitive issues, to come to their appointments with a family member who can help tell their story. Miss has noticed problems with remembering names over the last year. She still is very independent, and she's taking care of all of her instrumental activities of daily living and her ADLs at home. Her history is significant for hypertension, hypothyroidism, and when you look through her chart, you remember that Mrs. Smith is a retired high school teacher. She graduated from college. She was one 3 years ago, and in that sense, she's lived by herself in her own home. Her, though she's involved in her mother's life, lives about 30 minutes away from her. Taking through her medicines, which across all patients, whether they're suffering from dementia, mild cognitive impairment, or delirium, I recommend that medication reconciliation be done every single time because the older adults see multiple providers, and it's not unusual for a medicine to be added in when patients go to see other doctors. Hydrochlorothiazide is on her list. She can ask for an 81 milligrams a day and a multivitamin. Just a sort of editorial comment for folks here. None of those medicines from my eyes as a geriatrician look like they are that concerning. Her family history is significant for her father of a heart attack at 65. Mother died of a stroke at age 80. And towards the end of her life, her mother may have had memory problems. Unusual scenario for me to hear. Her review systems shows she had no falls, no automobile crashes, no checks, no change in mood, no weight loss, no social withdrawal, no delusions or hallucinations. You notice that those are questions that are a little bit different from the types of things that you ask in your review of systems typically, but those things that I ask about all the time when I see older adults who come in, particularly those with cognitive complaints. The exam shows that her vital signs are all within normal limits. She's got a soft systolic ejection murmur, lung clear, her cranial nerves are intact, strength on confrontational testing is intact, nose is intact, I see no ratcheting or cogwheeling, and she has a stable gait. I'll point just out why I'm looking at that part of the exam to this point. You want to look when you do a neurological exam on an older adult, signs that they have any full deficits, which could be indicative of a stroke, which has gone undiagnosed at this point. You'll notice please mute if you haven't. Someone has just joined the call here, and there's a lot of background noise.
Get the point settled, but you guys work on the table.
Okay. There's no ratcheting or cogwheeling. I checked specifically for that because I'm looking for signs of Parkinsonism, which could be associated itself, Parkinson's disease, that goes on for a period of time, cognitive impairment, but there are also certain types of cognitive impairment outside of Parkinson's disease that present themselves with Parkinsonism. We do an MMSC in the clinic with her, and she scored 27 out of 30. I always like to note what people lost their points for, and she lost 2 points for recall and 1 point for orientation to place. PAQ-9 score, which I also like to obtain on all my patients. This is a very nice tool to use, which I believe is open access and endorsed by a number of national committees for screening for depression. Her score was 2. Depression is incredibly common in older adults and is responsible for a lot of other sort of bad consequences. So we want to always be on the lookout for that. I had patients in the past who have bad sort of vegetative major depressive symptoms, and they present with complaints of cognitive impairment, and when you treat their depression, they get better. From a perspective. So, thinking over Ms. Smith's condition, what do you think she has? Now, if we were in a room all together, I would ask by show of hands what she has here. The choices are mild cognitive impairment, Alzheimer's dementia, depression, delirium, cognitive impairment, no dementia, which if you read old textbooks you may see, or normal age-related memory changes. Does anyone want to venture a guess? Someone who's brave.
I don't know.
I don't know if we can.
I've muted.
Oh, so this isn't going to work for you all to be brave with me, and somebody will pipe up. So, gosh, what condition do we assign to Mrs. Smith? So, the condition that I assigned to her is mild cognitive impairment. Why did we think that she had mild cognitive impairment, and what is MCI? I always tell my patients, MCI, it's not a phone company. They get a chuckle out of them when you tell them that. Now, we're doing that obviously with the Generation X folks. They probably wouldn't even understand what MCI was. But MCI can be thought as a point on the continuum between normal cognition and dementia. I talk about this scenario as being with a traffic light. Green is you have normal cognition, there's nothing to be concerned about. Yellow equates to MCI, with reason to have concern, and there's reason for us to pause and take a look at what's going on. And much like a yellow traffic light, if you do have MCI, you can either turn to red or you could go to green. You could go on to red. Red is considered typically a dementia category. And you can have people who revert to being on green. MCI affects between 14 to 18% of older adults when you look in series of older adults over age 70. It's associated with an increased risk of development of dementia. There's 3 to 5 times greater rate of conversion among people with MCI than among people with MCI. And the numbers that I typically quote to people, depending on the series that you look at, is that between 12 and 20% of people will go on to have dementia if you were to diagnose them at time 0 with MCI within a year. If you were to go as far out as 3 years, about 50% of those people who diagnose at time 0 with MCI would go on to have a dementia. I out to people so that they don't get scared when they see those numbers is that what happens to the other 50% of people? The other 50% of people in those cases, they either stay on yellow, they stay at MCI, and a proportion of them will revert backwards to being on green. So I point that out to people so that it's not all doom and gloom, and so that people really try and engage with me around promoting good brain health and trying to improve their cognition over time. As I point out here, my last point on the page, this is a condition which can reverse itself. I see that this is particularly true if we identify people who are on medications that have particularly bad cognitive side effects, or if we have patients who have untreated mood disorders. MCI, just to dive in a little bit further with it, there are different flavors of MCI. Some will differentiate between people who have amnestic MCI versus non-amnestic MCI. The diagnostic criteria differ a little bit by this. Amnestic MCI, as you could imagine, is a case in which people have problems with memory. This is reported by either the patient or their family members. You look for objective evidence of memory problems. You look for preserved general cognitive function to qualify as having amnestic MCI, intact ADLs. And this has to occur in the setting of no dementia. Across MCI diagnoses, they have to have excluded dementia. So non-amnestic MCI presents with preserved memory, deficits in other cognitive domains, whether that's executive function, language functions, visual spatial problems. In these patients, you'll notice, again, they have intact ADLs. That's a theme here that we see. People with MCI have intact function. And so that's something that really very easily, when you're talking to the patient, you can differentiate really pretty easily whether they have dementia or not. They're coming with cognitive impairment by just talking with them about what their functional status is day to day. Now, of course, that's complicated a little bit, right? Because nothing is easy. By the fact that older adults with cognitive impairment will sometimes present to the clinic and not be reliable historians themselves. So that's why it becomes super important to have to be able to obtain corroborating information from other providers, from other family members to tell you what's going on, in fact, at home.
Because it's on Wi-Fi.
Could I ask that everyone please mute your phone, please, if you haven't had a chance to do that. So, minimum diagnosis of MCI. You interview the patient, interview the informant. You get that corroborating information about what's going on with their functional level and their memory issues at home. Or let me be more specific there, or let me be more precise with my language. I've just used, the terminology that my patients commonly understand. Be clear with us, since we're groups of providers here, that's not just memory issues that I am trying to inquire about. Certainly people could come in and tell me that they have memory issues. I want to understand their decision making, which is to get towards executive function. I want to understand their language skills, whether there's any decreases in that. I want to understand their visual spatial function to talk with families. And as you see enough of these patients over time, you'll notice that if you ask these types of questions, you will start to get positive responses from some people in these areas. Other things that you want to do, medication review, of course, to exclude the taking and medications that could blunt their cognition. You want to do a physical exam, be very thorough for the things that could masquerade as cognitive impairment but affect people's cognition. Use the MMSE as a tool to chart where people's cognition is.
Oh, can you say what MMSE is?
The MMSE is the mini mental state exam. Sometimes called the Folstein mini mental state exam. I'll just mention, I guess, for the purposes of full disclosure for people, that the MMSE these days is a copyrighted exam. It was out and used in a lot of diagnostic studies over the years until the folks who originally produced the exam came back and started enforcing copyright on it. So it does cost some money to do. It's usually at $1 a test for it to be done. There is a group out there that will sell the test to you. and you can buy it. You can buy a nice testing version of it that you can use in your clinic at really reasonable prices. And usually I get 100 of them at a time or more. HQ9 is very available, used to screen for depression. I do lab testing to exclude for reversible conditions. I look for typically CMP to look for metabolic abnormalities. I'm doing CC to make sure that somebody have, an acute anemia, which is causing them to be fatigued and could cause their cognition to be off because you oxygenate those brain cells well. I look at H. B12 is typically part of my evaluation. And then in our clinic at UVM, we are obtaining RPRs on patients. That's a little bit more controversial, and not because you do anyone wrong by screening them for syphilis, because this is not done in every clinic out there. It's done really by protocol in our clinic, but I've worked in others where that just isn't standardly done. And obtaining. And there was a day and a time, just to be completely honest with people, where I didn't obtain a lot of imaging, and then I started obtaining imaging, and I identified what I felt was a clinically significant number of patients who had other things that could be affecting their cognition. Now, all things being equal, you're looking in older adults, so yes, this is different than looking in 20-year-olds, and you are going to find some abnormalities. Some of these things mean nothing, but sometimes they can be helpful to identify. I read a very striking case of a gentleman who came in who was very drawn, and his family had noticed that he was having some executive function difficulties. And I might have been initially inclined to just say that, this gentleman had functional difficulty, executive decline, but this guy meant a diagnosis of a dementia. And when I went to do his imaging, I found that he had a huge meningioma at the front of his brain that was pressing down on his frontal lobe and actually causing some small degree of herniation. We sent him over to the neurosurgeons pretty emergently, who took it out. And I went over the next morning to see this gentleman in the hospital. He was awake, alert, and talking with me, and then was able to describe, how he just couldn't make sense of the world going on around him before. He also, incidentally enough, then told me how agitated he was being made by the steroids that the neurosurgeons were giving him to control brain swelling, which was amazingly a conversation that I could never imagine having with this gentleman when I first saw him walk into my clinic. So there are reasons to do this imaging. You would know enough people, and you will find things that are clinically significant. Practical management, things to do with people. So when I am ruling a diagnosis like this, I like to do it in a sort of format of a family conference. All members of the family who are able to be there can receive the same type of information. This is part of I think, a approach that recognizes that the patient is not just the only individual you're treating. This is a communal approach where you realize that the patient is a member of a larger unit, and that frequently, as diseases with cognition tend to progress over time, it ends up that you are doing a lot of your work with supporting the caregivers. So it's important that the caregivers be brought up to speed from the start about what it is that they're facing. So I talk with people very openly that with MCI, there's little evidence for the role of routine use of drugs in the treatment of mild cognitive impairment. When I say drugs, I mean memory-type drugs, whether that's donepezil or memantine or one of the cousins of donepezil out there. There's little downside, though, to suggesting control of vascular risk factors, blood pressure control, diabetes control, lipid control. There's little evidence to suggest at this point that there are benefits from cognitive training programs that people might undertake. So, you can listen to enough late night TV if you happen to be an insomniac and see that these brain learning programs are sort of touted out there. I tell people, though, that while those programs may cost you money, and that could be a reason not to invest in them because you have an extra $300 to invest, there's really no harm that you're going to get from investing $3 by going to your local convenience store and picking up a book of puzzles and doing Sudoku every day for 30 minutes. I tell people that there usually is not a whole lot bad that's going to happen from you by getting outside of your house and stop looking at the same four walls all the time, getting out to places like senior centers and staying socially engaged. That type of direction are things that I suggest to patients that are really non-pharmacologic in nature. These people, how frequently am I seeing? I'm typically asking them to come back to see me in the memory clinic every 6 months to a year, depending on when I last saw them beforehand. Typically with MCI, we're not going to see changes that occur any more frequently than that or any more quickly than that. So that tends to be our interval. I'll say, though, that happens for me in the context of when I was practicing geriatric primary care. I would be seeing people typically every, 3 or 4 times a year, so every 3 or 4 months. So if I flip over and wear my different hat and see people just for cognitive issues, I would be asking them to come back every 6 months, which may be a little bit more frequent visits than potentially what colleagues on the call who are primary care providers are used to seeing adults who are otherwise doing well. They may think, gosh, you should come in about a year period of time, and more frequently than that. While that may be a way to sort of have good panel management over time, in people with cognitive impairment, a lot can change in between a year-long visit, and it's only when I know that things have been stable visit after visit after visit that I tell people, go out for a year and we'll see you in 12 months. I also like to keep my family members engaged, of course. Points here is that MCI is common among older adults. This exists on a continuum between normal cognition and dementia. The condition that's potentially reversible. It can, though, develop further into dementia, and that's a good reason to identify these people and to follow them closely over time. And my treatments focus on control of risk factors for worsening of cognition. And I also talk about those non-pharmacologic approaches that I've mentioned earlier. Move on to a second case here. This is the case of Mrs. Jones. Mrs. is an 81-year-old woman who comes into your clinic for complaints of memory problems with her daughter. Sounds a little similar to the last case, right? You never tell a geriatrician that I had an older woman who came into the clinic last week who had memory problems, right? That describes very frequently about 3/4 of the folks who we see. Mrs. Smith had lived by herself until a recent hospitalization for hip fracture. During that hospitalization, she developed behavioral problems at night that required use of risperidone. Eventually, she was discharged to her daughter's home, and she continues to receive the risperidone, 0.5 milligrams twice a day, ingested at her discharge 3 months ago. She's been on risperidone for a while. That was required to control behaviors that seem to be occurring at night. Hopefully, this sort of scenario is ringing bells in people's ears, and they're saying, I wonder what was going on before. So her past medical history, you drew it, and somebody has now added dementia to her chart. This was diagnosed during her hospitalization, and hypothyroidism. Her social history, she's a retired office manager at her local auto plant. She graduated from business college. She was 15 years ago. And now at this point, she's living with her daughter. Her meds include lisinopril, risperidone, and simvastatin. Mother died of a heart attack, mother died of a CVA, and the mother may have had memory problems. Sort of similar, right? No falls, but she feels unsteady on her feet. She's no longer driving, dependent on her daughter for help with dressing, feeding, and bathing. So there are those that functional level questions that we ask about. Answer within normal limits. Heart has a small systolic ejection murmur, a little bit lower extremity edema, no finger cogwheeling. I'll note again, this is something I look for the Parkinsonism. Recall that people who are on risperidone, other antipsychotic medicines can develop extrapyramidal symptoms from use of these medications. Another reason to look for this. Her C was 21 out of 30. She lost 3 points for recall, 3 points for orientation sorry guys, 1/2 second here. 3 points for orientation to place and 3 points for orientation to time. PHQ-9 is 10. Note she's distressed by her muddled thinking. What can we assign to Mrs. Jones? Is it AI, depression, delirium, or normal age-related memory changes? We know right off the bat that E is a distractor. It's not normal age-related memory changes. Take a look at her case. She has dementia. It's at the far end of our continuum of cognition that we described earlier. This is approximately 5 million older adults in the U.S. currently, and is projected to affect 13.8 million people by 2050. Numbers, there's a recent paper for those of you guys who are interested. I believe it showed up in JAMA Internal Medicine within the last month. Some work out of the Health and Retirement Study shows that maybe these projections that I show here on the screen are a little dismal, in that maybe we have done some good in decreasing the amount of people who are developing dementia, in that maybe there's going to be a decrease. It's still a decrease from 5 million older adults. I'm saying a decrease from 13.8 million. So we will only increase from 5 million to potentially 8 or 9 million, as opposed from 5 to 13. Which is still a heck of a lot of older adults to take care of, but still potentially what it could have been. We know that in an average panel of about 2,000 primary care patients, approximately 24 individuals will have dementia, and only 8 of those patients will be recognized. And there's data to say that of those patients who are recognized, that only about 4 of those people will be actually told that they have dementia. So their providers have recognized that they have dementia. So when you look at those types of statistics, it sort of shows, I think, to a lot of providers out there why it can be so difficult to sort of roll together the resources that you need to take care of older adults in your practices. It's because there's not a whole heck of a lot of them in at any one time. But when you look at them all spread across our health system, they are high. They do high intensity of health services, and we don't do a great job at recognizing them at this point. I think that recognition is a good point from which we need to start if we're going to make sense of how to manage these disease states. So dementia, you should recognize, of course, that dementia is a heterogeneous condition out there. Patients, when you talk with them about dementia, of course, they're going to jump right away to Alzheimer's disease. This is in front of their mind. I'm glad it's at the front of their mind when they hear about dementia. It's better than being a complete blank for them. But if you were just to play the statistics in your clinic and identify that somebody had dementia, if you were to try to subtype it from there, you'd be correct by picking Alzheimer's disease 60 to 80% of the time. Frontotemporal dementia is also common. We see it frequently. This presents with loss of executive function and frequently has personality changes with it. Lewy dementia tends to have the following three components to it. Really, you only need two of the three in order to sort of start nailing down that diagnosis. Hallucinations, typically they're visual, Parkinsonism, and then fluctuating mental status, which would be hard to disentangle at times from delirium. Vascular dementia you typically see occur where you have a story of stepwise deterioration of patients with an abrupt onset. The diagnostic criteria for identifying somebody as having a dementia is you have to have impairment in one of 5 cognitive domains. Just contrast that with what the old definition was for dementia. The old definition said that you had to have a deficit in memory plus one of the other domains. Now, it's just that you have to have impairment in one of the 5. So you can diagnose somebody with dementia if they have an impairment in just executive function and they have a problem with memory at that point. And that's sometimes hard for families to understand. And they say, oh yeah, her memory, my mother's memory is fine. But you start doing tests of their executive function and you find that they're having big problems with planning and organizing activities. I'll note this is the contrast with MCI, is that you have to have a decline in function for the person. So it has to be affecting their functional abilities and their day-to-day life. This does not occur exclusively. This cognitive impairment does not occur exclusively during delirium, and it's not better accounted for by other mental disorder, i.e. or e.g. major depression, or by untreated medical condition or use of a medication. So this is where it becomes really very, very important to understand what's going on likely with patients before they were brought to medical attention and understand when medicines were started in the story of cognitive impairment. So in the case of the woman who we're discussing in this case, she was somebody who was now functionally impaired. When she went to the hospital, she developed problems with behaviors at night. Behaviors at night sound very suspicious for me in retrospect as being indicative of somebody who likely was sundowning, was a common manifestation of older adults who have dementia. This woman who also was living on her own beforehand, which is also not an uncommon scenario, that you see that somebody is living on their own beforehand. There is nobody to provide you with a reliable story of just how cognitively impaired they were, and then they present to the hospital and things become unmasked at that time. Also, one of the things that we have to be careful around here with this patient is that she has been placed on Risperdal, and Risperdal can be confusing to, can induce confusion among older adults and muddle their thinking. So you question whether or not this is a fair test of her cognition at this point if she's on Risperdal 0.5 twice a day for control of these nighttime behaviors. I will say that her situation is very suspicious for her having a underlying dementia, but if I were going to be diagnostically pure about it, this would be a situation in which I would like to take her off of the Risperdal and retest her when she's off of the Risperdal to see how she does. Although there are certainly occasions in which these medicines get used, Risperdal, in the care of older adults, I'll say don't have FDA indications for the use of Risperdal, and these things are being used off-label. And in fact, there are black box warnings associated with the use of antipsychotic medicines, control of behaviors in older adults with dementia. That's something that you should be aware of, and if you ever were to start a patient on those medicines, you should having that discussion with families beforehand. So diagnosis, you'll notice that there's a lot of overlap with what I do with my patients with MCI. We interview the patient and the informant to get corroborating information. We do medication review, the physical exam, the MSC, the PHQ-9. We do the lab testing to exclude for reversible contributors, and we obtain imaging, usually obtaining non-contrasted head CTs versus MRIs for these patients. Discuss with families when I give this diagnosis. Again, much the same as what I did with MCI. I discuss mitigating factors that the medicines could be affecting her cognition, that she actually had an episode of delirium during the hospitalization, which could put her at risk for the development of persistent cognitive problems. Depressive symptoms could blunt her cognition. In this case, what I did with the patient, we planned to titrate her risperidone off. I want to evaluate the patient in 2 months to retest her cognition and mood. At that point, if the mood disturbance continues, you could consider treatment of depression for this patient with an antidepressant, because we saw her PHQ-9 was 10. Her mood may be better on its own just as you peel away the risperidol, and she feels that she can think more clearly. Treatment. I talk with people about controlling vascular risk factors, like I did with our patient with MCI. I talk with our patients about avoiding anticholinergic medications. Diazepam, diphenhydramine is a common offender. Look for acetaminophen PM that people like. I coughed a little bit yesterday when I was watching the TV and I saw that Aleve started to put out a product called Aleve PM, and it said for a great night of sleep. Now, I didn't pull Aleve PM off the shelf, but if I know other products branded as PM, it usually has diphenhydramine in there, and that's a real no-no for patients with cognitive impairment. Personalization, support, validate our caregivers, that's very important. Address key concerns, driving, cooking, wandering. Set our families up with resources, legal and financial planning. I establish goals of care with patients who I am talking about a diagnosis of dementia. And talk with them about the need to put together crisis plans for management. That if an older adult with cognitive impairment has an acute medical emergency that develops, they have a system of support that is to spring into action, accompany them as they go to places like the emergency department. Adults with cognitive impairment, particularly those with dementia, are at higher risk of going to the emergency department. And once they are in the emergency department, they're at higher risk of being admitted to the hospital, and they're at higher risk of returning to the emergency department within 30 days. These are all good reasons, if for no other reason than that we should try to recognize these patients ahead of time and put support systems in place for these older adults. A large amount of money is spent on giving care to these patients, but oftentimes this care sort of cycles after each other, and we don't sort of to the root issues that are at play here, that people need more support in their home. They need to be connected with services that hopefully can prevent situations from sort of spiraling out of control. I have family members when I give this diagnosis also the use of acetylcholinesterase inhibitors, like donepezil or NMDA antagonist, LaMantia. Key point takeaway from dementia: this is very common in older adults. It frequently goes undiagnosed. It exists at the far end of the spectrum after MCI. It may be associated with memory deficits, but does not have to be. It represents a change for the patient from baseline and causes functional decline. And treatment should include non-pharmacologic strategies, in addition to possible pharmacologic strategies. That there's an increased rate of emergency department visits, high rates of hospitalizations, and higher 30-day ED return rates for people who have this condition. I will run through in the next few minutes here very quickly so that we have time for questions, the case of Mr. Washington. Mr. Washington is a gentleman who received a consult request by another hospital service for him to be seen because he had developed acute dementia. So once you see the words acute dementia written down on the page with your consult request, you should hopefully be thinking, dementia is not something that develops acutely. It usually occurs over time, and you have to be really suspicious that maybe the cognitive problem, which thankfully your colleagues are recognizing, is not due to dementia, but in fact due to a delirium. This is a 75-year-old man, retired newspaper writer who fell 3 days ago and broke his hip. He had a successful surgery, but the night of the surgery he became agitated, pulled his own Foley catheter, tried to leave the unit, and had to be restrained. The family is distressed, the patient is distressed at what's going on, and the reason for your consultation likely was because the inpatient team was also distressed. And they shot up the flare gun and said, "We need your help." When you see Mr. Washington, he's a pleasant older man laying in his room with the lights off and the television on, confused. He's not able to meaningfully answer your questions. His medical history is he used to smoke. He has heart disease and COPD. His medications happen subcutaneously. Phenhydramine, which was to him as a pre-medication for blood transfusion, albuterol, nebs, metoprolol, aspirin, simvastatin, and even an oxycodone, acetaminophen combination pill. Signs are unremarkable. He's confused. He's not alert and oriented at all. He's hard of hearing. I'll note that being able to hear and interact with the environment around you is a big part of keeping older adults from becoming delirious in the hospital. He is clear to auscultation bilaterally, but he grabs at your stethoscope as you're trying to listen to him, and he mumbles throughout your exam, so you're trying to hear his lungs over top of him talking. He's able to cooperate with your neurologic exam. He's able to complete your MSE. And you do another test that you have in your back pocket, the confusion assessment method, for looking at whether this patient is delirious. He comes up as positive. So what condition do we assign to Mr. Washington? Hopefully at this point you're cues here that he has delirium. Delirium is a common complication of the care of older adults with illness. It affects approximately 10% of older adults in the emergency department who seek care there, and it's recognized in only a minority of those cases. It occurs in even more older adults who are hospitalized. 11 to 42% of older adults in the hospital will develop it, and large numbers of those older adults go unrecognized. It's associated with increased risk of death, hospital length of stay, and worse physical and cognitive recovery for these older adults. So this is not something that, is benign, as they're just confused and they'll get better. No, this is they're confused. It may in fact get worse over time. It exists in three forms: hypoactive, hyperactive, and mixed. In this case, our gentleman had hyperactive delirium, so it came to the attention of the team that was treating him. It frequently, though, can be hypoactive. Hypoactive delirium allows people with delirium frequently to fly under the radar. They are not recognized because they're not causing problems for teams or the nurses who are at the bedside with them. To the patients who sit there in the bed, keeping to themselves, not able to make sense of anything of what's going on around them. With delirium, it's sort of like pulmonary embolism. If you remember back from school, it's something that you have to suspect it. There is no one diagnostic test that's going to go ahead and make it flash across your radar screen. Features for it are the following four: acute onset and fluctuating course, attention, disorganized thinking, and altered level of consciousness. And to diagnose it, you either have to have one or two, plus you have to have features 1 and 2, plus E3 or 4. Commonly used tools to evaluate it are the CAM and the CAM-ICU. So the diagnosis, you want to talk with your family or the nursing staff and really nail down that you have an acute onset and you have a fluctuating course. You want to test for attention and disorganized thinking. And I have a few examples here of how to do that. I test for inattention by asking people to spell out the word "say the heart," and I ask them to squeeze my fingers every time that I say the letter A. They're supposed to let go when I'm not saying letter A. So we'll do that task together. I'll give a series of questions to test disorganized thinking. Will a stone float on water? Are there fish in the sea? Those are nice ways of getting at the disorganized thinking. Treatment for delirium is prevention. Prevention strategies include orientation, maintaining nutrition and the hydration, being restraints in lines when possible. So getting rid of the Foley catheter when it's not needed is really important. Pain, providing adaptive equipment for hearing and vision. You can identify it early so that it doesn't spiral and get worse. Treat precipitants, minimize time in bed, minimize restraints. And there's very limited evidence to support using antipsychotic medications. In fact, last week, there was a study that came out that shows that delirium at the end of life is not better treated by using antipsychotic medicines, and in fact may cause decrease quality care, and in fact may cause patients to die sooner. So delirium frequently complicates the care of older adults. It's with worse health outcomes for patients, including increased emergency department outcomes that you saw earlier. Detect requires thinking about it or screening for it. The CAN is the most popular delirium detection tool, and management strategies exist. So my summary here for you is that dementia, MCI, and delirium are three common conditions that affect older adults. Each have profound consequences for older adults and their families. Each have profound consequences for use of emergency services, and resources and strategies to exist to help manage these conditions. With that, we have a few moments here where we can open up the lines here for questions. We're opening up the line, so if anyone has questions, please. I'm all.
Have any questions for Dr. LaMantia? I've unmuted your lines from our side. So remember to unmute your line if you do have a question. Okay, if there are no questions, this presentation will be available on a recording. We are working on getting a link for all of the webinars for a recording, and we will send that to you. If you do have questions, you can email Dr. LaMantia, and the email is there. And we'll also be sending out within the next 24 hours those of you that have requested CME. We will be sending out the paperwork and the slides. If anyone has no questions, we will end the webinar, and thank you very much for your participation.